And I'm going to continue. Hello, everybody, and welcome to our 2020 VTE conference patient session. Delighted to have you all attend. And I'd like to first introduce Dr. Kevin Ryan, who's a consultant hematologist in the National Coagulation Centre in St. James's. And he's going to give us a talk now all about blood clots. Welcome, Kevin.
Thanks very much, Anne-Marie. I'm very happy and very much delighted to be able to talk to you this morning. And I think I've got the easiest job of the day because I'll be giving you just a very quick overview about blood clots, particularly blood clots in veins. And I think the harder jobs of going into much more detail about the various types of clots will fall to my colleagues over the next 2 days. But I do think it looks like it's going to be an amazing 2 days, and I'm very much looking forward to it myself. First, a little bit about me. I am a consultant haematologist. I'm based at the National Coagulation Centre at St. James's Hospital in Dublin, and I've been working there for the last 10 years now, although it doesn't feel like that. And my job really is split between treating people with bleeding disorders, but increasingly spent treating people with clotting disorders. And I think that's a reflection that of the importance of clotting in the community and how much of it there is out there, and a greater understanding that sometimes these are difficult conditions to treat, and that sometimes expert review is necessary to get the optimum management about them. What I'm going to be talking to you about today is a little bit about what clots are, how they form, what kind of problems they can lead to, and how they're managed. And I hope to have a little bit of time at the end to answer any questions you may have. So if you do have any questions, please feel free to ask them. First up, just a little bit about normal blood circulation. And this either you may remember from school, it may bring back nightmares, hopefully not. I'm not going to spend too much on it, really, other than to say normal blood circulation is critical to the body because it's required to deliver oxygen and nutrients to the body cells. And blood circulates obviously from the heart to the whole body, delivering oxygen and nutrients. And they're delivered by arteries leading from the heart to the body. Once the blood has delivered its oxygen and nutrients, it then returns to the heart through the venous system, which comprises all the veins of the body. And from there it goes to the lung directly to pick up fresh oxygen and release the waste carbon dioxide. And normally, to keep flowing, obviously, blood has to stay fluid. But at the same time, if we have an injury to a blood vessel wall, well, the blood must then clot to prevent excessive bleeding, because otherwise even a minor injury could result in us losing all of our blood volume. And that's a very tightly controlled process under normal circumstances. So it's critically important to keep blood fluid within the blood vessels, but at the merest hint of an injury, it must turn into a clot to clog the hole in the blood vessel and prevent excessive bleeding. Unfortunately, that system sometimes goes awry. And what we can see with that is clots forming inappropriately inside blood vessels, and that's a process called thrombosis. And it can be triggered for a number of different reasons, including injuries to the blood vessel or to poor circulation. In other words, the blood isn't flowing quite as quickly as it should. It stagnates, if you like, and slow moving blood is more inclined to form these clots within blood vessels than quickly moving blood. And then there are a number of conditions within the blood itself that may make it a bit more inclined to form these clots as well. And usually what you see is that it's not just one of these things that leads to a thrombosis, it's usually a combination of two or more. Once a blood clot forms, it will cause a blockage, or what we call an occlusion, within that blood vessel, and that prevents normal blood flow, as you can imagine. Blockages in arteries, they're the blood vessels that are delivering the oxygen and the nutrients to the various organs and cells of the body, will prevent oxygen and nutrients getting to whichever organ that artery is going to. And that results in the death of the cells in that area. And that's the process that causes things like heart attacks, where a blood vessel leading to the heart is occluded, causing some of the heart muscle cells to die, or a stroke, which is caused by a blockage in an artery going to a part of the brain, causing part of the brain cells to die. And that is probably about as much about arterial clots as I'm going to talk about today. And the rest of the time, I'm going to be talking about clots in veins. Blood clots in veins will block the blood return to the heart. So the blood at this point has done its job of delivering oxygen and nutrients, and it's on its journey back to the heart, where it is going to go from there to the lung to pick up fresh oxygen. And a blockage in a vein will prevent that normal blood return out of the area. And that usually will cause blood to build up behind that blockage in the vein, causing pain and swelling of the affected area. More seriously, occasionally what can happen is that a portion of that clot may detach from the vein and travel towards the heart. And that process of the clot traveling through the venous system towards the heart is called embolism. There are different types of venous blood clots that we see. About 2/3 of them we call deep venous thrombosis, and this is where the blood clot is formed, usually in a limb, usually the leg, and it causes pain and swelling of the affected leg, as you can see on that picture there. About 1/3 of the time, the clot will detach and travel through the blood system to the heart, and from there to the lung, where it becomes wedged in the blood vessels of the lung, and that's called a pulmonary embolism, or PE. And very rarely we see clots happening within the veins of the brain, and they're called cerebral sinus thrombosis. I'm going to talk a little bit about that, each of those in turn. So as I said, the majority of the clots that we see occur in the legs, about 2/3 of them. And they usually start in the calf. And the reason for that is that the calf is the part of the leg that has the slowest blood flow. So if you remember from earlier, I said one of the things that can lead to clots forming is a sluggish blood flow. And the veins in the calf have the slowest blood flow in the leg, and that's why the majority of clots in the leg will start off in the calf. And about 2/3 of the clots that form in the calf, if you do nothing with them, will go away all on their own within about 72 hours. It's very rare for a clot within the calf to detach and embolize. What's a little bit more serious is that sometimes the clot that has started in the vein will grow and gradually extend upwards into the calf or above the knee. And those above knee DVTs are a little more serious. They're a little more serious because they're more inclined to cause problems with pain and swelling. An awful lot of the calf DVTs are silent. People don't know they have them. And they clear up, as I said, on their own. But once the clot has extended to above the knee, the majority of people will have problems with pain and swelling in that leg. And as I said, about 1 in 6 of those clots that start in the calf will end up extending to above the knee. The symptoms of a DVT in the leg usually are things like pain and tightness, maybe some people will describe, in the calf or the thigh, on top of some swelling and some redness. The pain is usually fairly constant. It doesn't tend to come and go. And a lot of people describe it as maybe feeling like a muscle cramp or a stretched muscle. And they won't always recognize it for being down to a clot within the leg. And what I often hear people say is that they had this problem with their leg going on for days, and it was only when it wasn't really getting better that they went to have it investigated. As I said, occasionally, these clots that are above the knee, in about half the cases, a portion may detach and travel through the veins towards the heart, and it will pass through the chambers of the heart. There's nothing within the heart itself to block that blood clot, and where it goes from there is into the blood vessels leading to the lung. If you remember, the blood is passing from the heart to the lung to pick up fresh oxygen. As it's going through those blood vessels in the lung, think of it like a tree. The trunk of the tree is quite wide, but as you go deeper and deeper into the lung, the branches break off and become smaller and narrower. And what happens is that eventually the clot will meet a blood vessel that's too narrow for it to pass through, and it becomes wedged or lodged at that site. The bigger the clot, the bigger the blood vessel it will block off. And what happens then is that the blood flow will be blocked going to that part of the lung. That will cause people to feel short of breath because not all of the blood is now picking up fresh oxygen. So now the body is struggling to get enough oxygen to the various cells of the body, and people will feel that as shortness of breath. Usually as well, people will note that they have a very sharp or stabbing pain in the chest. That's usually worse if they take a deep breath in or cough. And it's usually very well localized. It's not a vague discomfort. People will say, no, I can feel exactly where it is. If I take a deep breath in, it's feeling almost like I'm being stabbed in that area. And a lot of people will report that they have palpitations with it. And the reason for that is that the heart is now having to work a little bit harder because of the blockage to try and force blood through into the lung. That puts a little bit of pressure back on the heart, and that leads to the sensation of palpitations. Occasionally, people will feel a little bit lightheaded with this, as if they're about to faint or dizzy. And some people will have a dry cough, or rarely a cough that's bringing up small amounts of blood. And again, the symptoms of a PE tend to come on quite quickly. So unlike the clots in the veins of the leg that can be developing over days, the symptoms of a clot to the lung usually come on within minutes to hours. It is important to state that while the majority of PEs have come from the leg or have come from elsewhere and travelled from there to the lung, not all people will report having had symptoms of that preceding clot. A lot of the time, those initial clots are silent. They haven't caused significant pain or swelling, and it was only when the clot detached and travelled to the lung that people noticed that something was wrong. And unfortunately, if the clot that travels to the lung is big enough, it will block off so much blood to the lung that that person will pass away from that they're not getting enough oxygen to keep themselves alive. And that unfortunately happens in about 15% of people. About 1 in 6 people who get a pulmonary embolism will die of that clot. And what I think is quite scary is that of that 15%, 2/3 will die within an hour of them first getting those symptoms. In other words, far too quickly for them to get a chance to get to a hospital and get treatment for that clot. If you've managed to get through that first hour and get for medical treatment, the treatment is quite effective, and once you get through that first initial period, the vast majority of people will do very well. Finally, I'm just going to have a few words about cerebral sinus thrombosis, and I know that you're having a talk about cerebral sinus thrombosis later on by Dr. Lavin. She's talking about that tomorrow, so I'm not going to spend too much time on this, other than to say the cerebral sinuses are the main veins which drain blood from the brain. They're located on the surface of the brain underneath the skull, and thrombosis within them we see occasionally. About 1 in 50 total venous clots that we see are made up of these cerebral sinus thrombosis. So overall, it's a rare condition. And the kind of symptoms that they cause are headache or visual disturbances. Some people will notice limb weakness, almost as if similar to symptoms of a stroke. And in severe cases, people may develop seizures or even coma. And they can be very unwell with that. So now that we've talked about the various types of clots, I'm just going to have one slide about how big of a problem this is, how many people get them. And what we know is that per year, we see it in about 2 to 3 people per 1,000 out there. And if you extrapolate that, we see about 11,000 cases of venous thrombosis in Ireland every year. It's estimated that there's about 1.1 million cases of venous thrombosis in the EU every year. And if you extrapolate that out, there's almost 10 million venous thrombotic events in the world every year. So it's a very big problem. And it's one of the leading causes of heart disease mortality in Ireland at the moment. What causes them? Well, I tend to break this down into personal factors, in other words, things about the person themselves that are leaving them a little bit prone to developing clots, and then external factors, things that happen to the person. They're usually temporary or transient that increase their risk of getting a clot. And I'm going to go over these one by one very, very briefly. First to say, unfortunately, is that as we get older, our risk of getting a venous thrombosis does increase. And if you look at that graph, if it's clear enough for you to see, you can see that venous thrombosis is a rare event in people under the age of 40. It's very, very rare in children. We see it small numbers of people in their 20s and 30s. But unfortunately, once you go over the age of about 50 or so, that risk starts to increase quite dramatically. So if you look at it, we estimate that maybe only 1 in 10,000 people under the age of 20 get a clot per year. But if you go into the age of 80 or so, you can almost see that it's becoming up to the region of about 1 in 100 people per year in that age group get a clot. Unfortunately, there are certain lifestyle risks that probably a lot of us could be guilty of that put us at risk of getting these clots. Probably the biggest lifestyle risk is being overweight. A lot of people assume that it's smoking, but in fact, being overweight is probably a bigger risk factor for venous thrombosis than smoking. Smoking is bad for lots of different reasons, but when it comes to venous thrombosis, it's probably beaten by being overweight. So if your BMI is over 30, we know that your risk of getting a clot is increased by 3 times. If you smoke, the risk of getting a clot is doubled. And we also know that people who have a sedentary lifestyle, maybe office workers or maybe have reduced mobility for a different reason, are also at increased risk of getting a clot. That final one, it's difficult to put a number on what the risk is with that, because, you know, how do we define what is sedentary? And there's varying different degrees of that, and the risk is probably on a spectrum. In other words, the more active you are, probably the lower your risk of getting a clot is, but there's no absolute cutoff. Pregnancy is a risk factor for developing venous thrombosis because of the changes that happen in pregnancy to reduce the risk of bleeding at the time of delivery. So there are hormonal changes in pregnancy that are designed to prevent bleeding at what is a challenge for the clotting system with delivery. And those hormonal changes increase the risk of developing a clot by about 10-fold. So when I said earlier on that the risk of a healthy young person getting a clot is about 1 in 10,000, during pregnancy that jumps to about 1 in 1,000. And unfortunately, it does remain one of the biggest killers of pregnant women in the developed world. So if you look at the reasons why mothers and pregnant women die, the biggest majority of that is taken up by the development of venous thrombosis. Another risk that we probably can't do anything about is our family history. And we know that if we look at some families, there is an increased risk of developing thrombosis in certain families. So we know that people who have family member, or particularly a first-degree family member, that's a parent or a sibling or a child, who's developed a clot, that they themselves then have a higher risk of getting a venous thrombosis themselves. The risk is even higher if the family member's clot developed out of the blue. In other words, that there was no clear trigger that we could identify to explain the clot. And that just seems to suggest that maybe there was something that the person had inherited that was particular to them and maybe in the family that is increasing the risk of developing a venous thrombosis. And we do know that there are certain conditions that are inherited that increase the risk of developing venous thrombosis. And I sometimes get asked an awful lot about what those causes are and if there are tests we can do to identify people within families who have inherited the risks of developing venous thrombosis. And certainly the good news is that we do know some of these conditions that are inherited that increase the risk of venous thrombosis. But the bad news is that it's not very helpful testing. And the reason for that is that if we look at families with a clear history of venous thrombosis and we run the tests that we currently have, in half the cases, we will not see any abnormality whatsoever. And that's not to say that there isn't an abnormality there. It's just saying that whatever abnormality might be there, we do not have a test for. So if we see a family and there's a very clear history of clotting within it, we can be fairly certain that there is something in that family that is being passed from generation to generation that is increasing the risk of thrombosis. But whether we have a test to identify it or not is a very different question. So what I have said there is that testing is normal in up to 50% of affected people in families. So the test isn't very sensitive. So a negative test result does not put you in the clear. On the flip side, to make things even worse, testing often does identify variants which are not very significant. So in up to 1 in 10 people out there, if we do these tests, we'll find an abnormality, but they probably don't confer a very significant risk in developing a venous thrombosis. So a positive test result doesn't necessarily mean that you're at significantly increased risk of developing venous thrombosis either. And the vast, vast majority of people who do come back with a positive test result will never have a clot. So if you follow them over time, once you've identified them as having a risk of a clot, what we find is that the testing doesn't necessarily identify the people who will go on to have a clot. So in other words, the testing is not predictive either. And all of that means that the testing is pretty rubbish. A positive or negative test result will not change how we treat a clot. It won't predict the people who will have a first clot particularly well. It certainly doesn't identify people who've already had a clot as to who might get a second clot, and therefore it's unlikely to be helpful for most people. So I found that over the last 10 years, I've been doing this testing less and less often because I just find it doesn't help people. I think one of the biggest risks, and this is an external risk factor, is the presence of illnesses that may increase the risk of venous thrombosis. And there's a big long list of them. And again, people will be discussing each of these conditions later on in a bit more detail. So I'm just going to mention them here. Particularly cancer. We know that cancer is a significant risk factor for the development of venous thrombosis. And what we see is that about 1 in 8 people who have cancer will develop a venous clot at some point over their course of treatment. Other conditions that increase the risk of thrombosis are what we call the inflammatory conditions, things like arthritis or inflammatory bowel disease, because inflammation within the body is a very significant driver of thrombosis. The inflammatory system and the coagulation system are closely linked. And again, because of that, we also see an increased risk of thrombosis in people who have significant infections or sepsis, particularly those that have required hospitalization. On top of that, there are some kidney diseases and some liver diseases that are particularly prone to thrombosis. And there are some autoimmune conditions, for example, antiphospholipid syndrome, that can particularly drive thrombosis. And again, Dr. O'Connell is talking about antiphospholipid syndrome tomorrow, I believe. Surgery is also a risk factor for developing thrombosis. And the reason for that is that when you have surgery, you tend to have, your mobility is impacted for quite a significant time after that, depending on the type of surgery that you've had done. And also going in with the various incisions and so on will cause some vessel damage, some blood vessel damage. And if you remember from one of the earlier slides, vessel damage does lead to an increased risk of venous thrombosis. And usually if you're having surgery, you're having it done because you have an underlying illness. And as I said, those illnesses may themselves be driving an increased risk of thrombosis. What we do see is that the longer the surgery, the higher the risk of developing a clot. Orthopedic surgery, particularly joint replacement, knee replacements and hip replacements, are particularly risky surgeries because, again, they're long surgeries and your mobility is particularly impacted following those types of surgery. And any surgery that's associated with a longer period of immobility will increase the risk of getting a clot. Not to mention, as I said, some underlying conditions that the surgery might be being performed for can drive thrombosis, for example, cancer. There are some medications that people can take that might increase their risk, and the big culprit here is estrogen. So hormonal medications that contain estrogen are known to increase the risk of venous thrombosis. And we find estrogen in two particular types of medication, the combined oral contraceptive pill and hormone replacement therapy. This is another question we often get asked, and what we would say is that not all oral contraceptive pills are the same. So some types of oral contraception have a very high risk of venous thrombosis, particularly the third generation preparations. They're the newer ones, funnily enough, whereas what we call the second generation preparations, which have been around for a little bit longer, actually have a slightly lower risk of venous thrombosis, particularly ones that have a low estrogen content. And our advice around these type of medications is that people who are at particularly high risk for venous thrombosis, for example, maybe they've had a clot before or they have a significant family history of thrombosis, should not take them. If your risk maybe is a little bit lower and we're saying that, well, yes, you could take these preparations, we would say that you should be aware of the increased risk with their use, and if possible, try and use one of the ones that carries the lowest risk of thrombosis if you can. And finally, another big one, and Dr. Ewens is following me today talking about this particular problem, is hospitalization. And I suppose hospitalization is a perfect storm because it brings together an awful lot of those preceding issues I talked about that individually can lead to thrombosis, and it puts them all together in the same person. And what we find is that when you're in hospital, your mobility is significantly reduced because you're unwell, you're not feeling well, maybe you've just had surgery, maybe you've got significant problems with pain or so on. And so an awful lot of people, their mobility is significantly impacted once they're admitted to hospital. On the flip side, what we sometimes see is that people who could be up and about more tend not to when they're in hospital. They almost feel they have to stay in their pajamas and have to stay in bed or close by their bed. And we in the hospital have a name for that. We call it Pajama Paralysis. And what we try and encourage is that as soon as you do feel up to being up and about, that's exactly what you should do. What we see is that about 50% to 75%, a half to three quarters of all venous thrombotic events occur either while somebody is in hospital or within 90 days of them having been discharged. So if you look at the Irish figures, if you remember, I said about 11,000 venous thrombotic events happen in Ireland every year. Well, about 8,000 of those are probably related to hospitalization, and that is a significant number of events. And People always ask me about the risk of getting a clot on a long-haul flight, and my answer to them is, well, you're 100 times more likely to get a clot from being in hospital than you are on a flight. So to kind of put it in context. Talking about flying, this is the risk of getting a clot per million people. So you can see here the numbers along the side there, and this is per million. And there's nothing particular about flying that increases the risk of getting a clot. It's just the fact that you've been sitting in a single spot for a prolonged period of time. It's the immobility, particularly with limited leg room, where your knee is bent at 90 degrees for a long time, and that 90-degree bend in your knee really does restrict the venous circulation out of your calf. And as I said, the majority of venous clot events do actually start in your calf. And the longer you're sitting in that position, the higher your risk of developing a clot is. But even for very long haul flights, greater than 10,000 kilometers, you can see the risk of getting a pulmonary embolism is about 5 per million. So very, very rare in the overall scheme of things. And our advice to try and avoid that risk really is to avoid the immobility. Try and stretch the legs as often as you can, keep the circulation moving. And other things that help are investing in a pair of the flight compression socks that you can get in the chemist, just to help with the circulation in your calf while you're on board. And also maybe to try and nab a Nile seat if you can, because it gives you slightly more leg room. And then good general advice is probably to keep well hydrated during the flight and just avoid maybe excess alcohol or the temptation to pop a sleeping pill to get through that flight sooner, because they will have you asleep in your seat, not moving. I think the big point really that this slide that I very poorly put together myself is to try and show that it's usually not a single risk that causes somebody to have a clot, but that multiple risks have come together. So maybe somebody has a family history of venous thrombosis, and that on their own wouldn't have caused any problems, but it was when that person maybe started the oral contraceptive pill, or maybe had surgery or developed an underlying illness, that several risks came together and added or even multiplied together, and eventually their risk was over that threshold line, and it meant that that person developed a venous thrombosis. So as much as we can do really is to try and modify and reduce those risks as much as we can. But after all of that, and again, I think that this is an important point, from about a quarter to a half of cases, even though when we go through talking to somebody who's had a clot, we don't identify a cause. So an awful lot of times we classify these clots as unprovoked. We can't find a clear reason why that person developed that clot at that time. How do we manage them? Well, the mainstay of management of thrombosis is blood thinning medication. So this is what we call anticoagulation. And anticoagulation is a medication that slows and reduces the ability of the blood to clot. It doesn't actually break down the clot that's already there. What it does is it stops that clot from extending or from new clot forming, while the body's own mechanisms, which are very effective, break down the clot already formed. So what we're really trying to do is keep that clot from getting any bigger, to allow the body a chance to get rid of it on its own. And it does that very effectively, but it does take time. So once you start anticoagulation for treatment of a clot, it does take weeks to months for that to fully have its effect. What do we do to try and reduce the problem with clots? Well, the most important thing probably is try and prevent anybody having a clot in the first place. And that really relies on identifying people who are at risk of developing it. So that may be somebody who has a family history of clotting, or has those underlying illnesses that may leave them prone to clotting, particularly if they're undergoing certain types of surgery, or in hospital for whatever reason. And what we do for those people is we use anticoagulation as a preventative. So we will give people anticoagulation during hospital or following surgery, particularly orthopedic surgery or surgeries for certain types of cancers, for up to 5 or 6 weeks after the surgery to prevent them getting that first clot. And the main medication we use for that is those heparin injections, and any of you who've been in hospital will be familiar with those daily injections, which are designed to prevent these clots from forming. Once the clot has formed, as I said, we then rely on anticoagulation to prevent it from getting any bigger while the body breaks it down. And they're the main agents that we use as anticoagulation at the moment. The old one, warfarin, heparin injections, or the newer oral agents. Warfarin's been around for decades. It was first marketed in 1954, and it was made famous by Dwight D. Eisenhower, who was President of the United States, was put on warfarin following a clot, and it was widely known about. And it really popularized the idea that warfarin was a safe and effective medication. He looks quite statesman-like there. You kind of, you'd almost miss it. But the problems with warfarin is that, and anybody who's been on it will know it, is that there is a large variation in effect from person to person, and a large variation in effect from time to time in the same person, which means that there's poor predictability. So we can put somebody on a dose of warfarin and not really know if we're giving them enough, too much, or just the right amount. And for that reason, we really need to monitor the effects of warfarin using the iron ore blood test every couple of weeks or so. And we know that if we have poor monitoring of that warfarin effect, we see people who get breakthrough clotting events because they haven't been on enough warfarin, or people who run into problems with bleeding because they've been on too much warfarin. And this is just showing the time and therapeutic range. In other words, how much time is somebody spending where we would like them to spend their iron ore value. And the better their time and therapeutic range, the fewer bleeding or clotting events that those people have. And what you can see here is that overall, we achieve a time and therapeutic range of somewhere between 55 and 80%. And the real purpose of this slide is to show that the more that people are involved in their own testing and management of the warfarin, the better their time in therapeutic range is. The benefits of warfarin are that it's widely used and people are very familiar with it. And also it has a long duration of action. It works for several days. So if you miss a dose, it doesn't have an immediate effect on it. And it's also easily reversed. Also, we know that it provides better anticoagulation for certain conditions. So we would use it as the anticoagulant of choice in certain conditions such as antiphospholipid syndrome. Heparin has also been around for a very long time. It's only available as an injection. There's no oral form of this because we can't absorb it from our gut. And it has quite a short duration of action, less than 24 hours. Also, we know that people who've been on it for a long period of time can run into problems with bone thinning or osteoporosis in later life. So we tend not to use this for long-term use in the majority of people, unless there's a reason we can't use a different anticoagulant option. But what really has taken over in the last 5 years or so are these newer agents called the direct oral anticoagulants. They've been on the Irish market since 2014. There's 4 different products available at present. And for the majority of people, they're shown to be as effective and as safe as warfarin. And they're taken, depending on which one you're on, once or twice daily. The advantages of them is that they are more predictable. If you take the correct dose, then we know the effect is right for you. We don't need to monitor the effect on the blood, unlike warfarin. The problem with them is their short duration of action. So if you do miss a dose of these, the effect wears off very quickly and very suddenly you're back at risk of developing a new clot again. So it's not as forgiving as warfarin if you do forget a dose here or there. And except for Dabigatran, there's no fully effective reversal agent available in Ireland as of yet. Now that is changing. There has been a reversal agent developed for the other 3 agents. It has received its license for use through the European Medicines Agency, but it hasn't yet been marketed on the Irish market. They were hopeful of getting it out early next year, but we'll keep you updated as to that. Finally, we're going to talk a little bit about how long we keep anticoagulation going for. And as I said, it does take a number of months once the clot is formed for anticoagulation to get rid of it. And as a general rule, we would say that everybody needs at least 3 months of anticoagulation to allow that to happen. In certain cases, we may need to extend it beyond 3 months, for example, for people with cancer or people who have ongoing problems for new clots forming, for instance, significant immobility. And in those people, we may need to keep the anticoagulation going until that risk has fully resolved. But in certain cases, if we think the risk of getting a further clot is very high, we may need to keep the anticoagulation going indefinitely to prevent recurrence. And in this group of people, the anticoagulation is no longer treating the initial clot. It's been used purely to prevent a second clot from occurring. So it's important to know what the risk of getting a further clot is. And what's clear to us is that the type of clot is probably the most important reason, or what triggered it. And we know that if your clot was triggered by surgery, once you've recovered from surgery and are off anticoagulation, your risk of getting a second clot is about 1 in 30 a year. If you've had a trigger, like pregnancy or being in hospital or being on the pill, but it wasn't surgery, the risk is a little bit higher. It's about 1 in 20 a year. But if there was no clear trigger identified at all, as I said, we see that in a large number of people, well then the risk is actually about 1 in 10 a year. And the other thing that predicts recurrence is that men have a slightly higher risk of recurrence than women. When we're making the decision to extend anticoagulation, what we try and do is an individual assessment for each person. We try and estimate what their risk of getting a further clot is, and we balance that against the risk of them running into difficulties if they stay on anticoagulation. And the big risk of being on anticoagulation is bleeding. And the risk of significant, and by that I mean life-threatening or even fatal bleeding on anticoagulation, is about 1 to 2% per year, maybe a little bit lower with some of the newer direct oral anticoagulant agents. So when we see people who've had a clot and we're trying to make this decision, we try and work out what their risk of significant bleeding is. We try and work out what their risk of recurrent anticoagulation, of recurrent clot off anticoagulation is, and we balance them together. And if that person has a low risk of getting a new clot, for example, their clot happened after surgery, or if that person has a very high risk of bleeding, for instance, maybe they've had bleeding problems while on anticoagulation already, we might decide that on balance it's better to stop the anticoagulation at that point. On the other hand, if they have a very high risk of recurrence, for instance, maybe their clot happened out of the blue, there was no clear trigger, particularly in men, and we know that they have a high risk of recurrence, and if they've managed their anticoagulation very well, well then overall the risk versus benefit would favour continuing on anticoagulation. And if you decide to continue on anticoagulation as a preventative, we try and keep that going indefinitely, because it only works as a preventative while you stay taking it. As soon as you stop it, your risk of recurrence comes back. And this is my final slide. It's just to say that after all of this, we do recommend that people who have had venous clots stay linked in with their medical team, either their local GP or with a specialist hematology clinic for ongoing regular review. And really what that does is it helps identify any problems with bleeding while on anticoagulation, helps identify any clotting problems that may have happened despite being on anticoagulation. And all the time we're reassessing that risk-benefit analysis, and people change over time, and sometimes that risk-benefit analysis changes over time. So just because a decision was made a year ago or 10 years ago doesn't necessarily mean that it's still the right decision now. So we always rethink that and have a further discussion about whether the right thing is to stay on anticoagulation or not. When you're on anticoagulation, it's also very important for us to know if there's been any other changes in your medications or any new medical issues that can affect your anticoagulation. And it also allows us to give advice to people around what to do around the time of surgeries, endoscopy procedures or scope tests that may want us to temporarily hold anticoagulation to prevent bleeding at the time of those invasive procedures. And as always, the field keeps changing. So the advice changes, the medications change, and sometimes we can give better advice to people or more up-to-date advice that might change how we manage them. So I think for that reason, a review on a regular basis can be really helpful. And finally, just to say thank you very much. And if people do have any questions, I'd be more than happy to take them.
Thank you so much, Kevin. I'm sorry about the slide issue, but it was an absolutely fantastic talk. And we're getting really great feedback here. I have a question from Nicola. Is there a risk ladder that tells you if you have maybe 2 of the risks, then your chance is 50% higher?
It's a very good question. There are some kind of tools that we use to try and put risks together and see if that we can get kind of an overall risk picture on somebody. They're not very good, so they're not as good as we would like them. What we would always say is that somebody should have an individual risk assessment. So anytime somebody comes into hospital, same happens during pregnancy or before starting any medication that might increase the risk of clotting, that tries to plug in all those various different risks and come up with a decision as to whether we need to use that anticoagulation. We do it quite a lot in the maternity setting. And we also do it to anybody who is admitted to hospital. But I have to say they're not very good at giving a number. So if somebody asks, well, what is my risk? The honest answer is we don't know. And people are trying to work those tools out to give us better information.
I think probably everybody's different. Everybody is different, and we kind of need to get to know ourselves. If we clot, we kind of have a fairly good idea ourselves. How we are and how we prevent our risk. I think probably now is a good time to encourage people to ask for a risk assessment if they are going into hospital.
Absolutely, and I think there's a lot of recognition now that hospitalization leads to a high risk of developing clots, and certainly. Hospitals and medical professionals and nursing professionals are really being encouraged to think about this and do the assessments, not just when somebody comes into hospital, but to continually do it for people who maybe require prolonged stays in hospital, to make sure that it's being thought about and that the people who should be getting the preventative medication are getting it. And I would really encourage people that are going into hospital to be aware of this as well and to ask about it. And don't be afraid to say, well, am I at risk of getting a clot? Should I be on medication to prevent that clot? It's not right for everybody. This medication does increase the risk of bleeding. Some people may be assessed and the decision may be that you don't need it, but at the same time, it's important that they are being assessed and that a decision is being made.
Okay, that's great. I'm just conscious of the time now because Dr. Yoon is lined up now to come on next. Thank you so much, Dr. Ryan. I really appreciate it, and we really enjoyed your talk. Thank you.
I might forward my slides on to you, Anne-Marie. I'm sorry that there was an issue with them.
Oh, that's no problem. Your talk was amazing anyway. Thank you.
Thanks, Anne-Marie. Thanks. Bye-bye.
Bye-bye.